Hi, I'm Mike Brampton.
And I'm Julian Ho.
And welcome to episode of
7, 6, 8,
8.
somewhere between 6 and 8. Okay, episode 6, break. Episode 7, break. Episode 8, break. And then Alicia will work out what one it is and get rid of the rest.
Of Veterinary Ramblings.
Hey, and good evening to you, Mike.
Good evening. I've got one over here, actually. I've got an exotic mix one tonight. You'll find out in a minute.
I can't wait to see. We've got a guest on tonight, Mike.
We have got a guest. I think you'll find him great fun. His name is Andy Langdown. And
Andy Langdown. Now, you told me about him before. He's one of your cycling buddies.
He is one of my old cycling buddies. Still is, sort of, apart from I don't ride a bike anymore. And he goes by the name of Mr.
Not Doctor. Oh, so he must be a surgeon then.
Not Doctor. Great. He's a surgeon. So great. Andy Langdown, Mr. Andy Langdown, is an orthopaedic surgeon down here on the south coast. And I think he specialises in endoscopic surgery. So let's get Andy Langdown in and let's ask him. Andy, good evening.
Good evening. How are you guys? All right?
Excellent.
We're fine. How are you, Andy?
Yeah, I'm just putting you on full screen here to get the full effect, really.
Hi, I'm Mike Brampton.
And my name is Julian Ho.
Welcome to Veterinary Ramblings.
Those who are using video may notice, if they've seen the previous episodes and they're not getting treatment for it, they may notice that, in fact, that this has changed. This used to be a bromeliad ananas species, but now it's actually cucurma. And cucurma...
No, I'm not wearing that. I'm not having that, Julian. I think...
Bottom line is you've just had lockdown and a haircut.
Exactly. That's exactly what I was going to say, Andy. That's exactly what I was going to say. Andy,
Mike, we're on the same wavelength.
Yeah, absolutely. I've just introduced you as Mr. Andy Langdown.
Oh, yeah, okay.
Well, it's interesting. There's an interesting comparison here because Julian, I don't know how many degrees Julian's got, but his latest one was a veterinary degree. And traditionally, vets have always been called Mr., Miss, or Mrs.
Very few people call me Mrs.
Very few. Yeah, a number call him Miss, but that's another.
Only at weekends.
No. It's something to do with this catheterization technique.
Yeah, another miss. Yeah.
but it was an interesting thing here because obviously, Andy, you studied medicine, and so you first graduated as a doctor.
Mm-hmm.
You then spent nth number of years in too many in extended studies and spending time on rotation and studying to specialize in orthopedics and to become a Mr. It's only recently that vets who have taken either a 5 or a 6 year or sometimes in some cases even a 7-year degree have been allowed to call themselves doctor.
Yeah.
And of course, all the doctors of philosophy are now up in arms because they did their first degree and their second degree and their PhD to earn their doctorship or doctorateship or whatever you want to call it.
But you know the history of the Dr. Mr. saga.
I know at least one myth of that history, whether it's true or not, about the best surgeons being butchers in those days.
No, it was originally the Royal College of Barber, or the College of Barber Surgeons of England. Okay, so they applied to have their members, and there were probably only about 20 of them at the time, recognised as doctors because they were performing treatments on patients. The Royal College of Physicians basically, excuse my French, said, fuck off, you haven't got a medical degree, you can't call yourselves doctors. So there was a core group of about 5 of them that did actually go to medical school, got a medical degree, became entitled to call themselves doctors and said, fuck off, we don't want to do that. We're going to call ourselves Mr. We're better than you. We're doubly qualified. and the old white and red revolving thing for the barbers, blood and bone, as a result of the College of Barber Surgeons of England. But that was given a royal decree somewhere in the 1700s, so it became the Royal College of Surgeons of England. But we today remain the only Royal College of Surgeons, those in the UK, where our surgeons are not known as doctor, they are known as Mr. Now, to flip the coin, and this is why I said you can call me what you want, Mike, because I am now a visiting professor of orthopaedic surgery in Dubai.
Right.
And it's fascinating there, because wherever you go in the hospital there, they will call me Dr. Andy. Dr. Andy this, Dr. Andy that, whatever. And it's totally different to get used to. It's just a cultural thing. It's absolutely fine. If you go to the States, your doctor. Mr. is very strange to them over there.
Yeah. I used to work when I did HIV research. My boss, a lovely guy, he was Austrian, and he was called Herr Professor Doctor. Now he was a medical doctor, so he got a medical doctorate degree. He then did a PhD, and so technically he called himself, or was allowed to be called, Herr Doctor. But then he became a professor, so it became easier because it was Herr Professor Doctor, not as clumpy as Doctor. So, are you a general orthopod, Andy? Or do you have
I'm a hip and knee specialist.
Oh, yeah.
I do general trauma, so whatever, I'm on call tomorrow, so whatever comes in tomorrow, if it's within my remit to do it, that's fine. But
is that like broken bones then, Andy?
Sorry?
Is that like broken bones? He has a fracture. I can fix it.
Yeah, he has a broken bone. You have to fix it. It is the law.
Okay. Gordon's alive! Seems to have streamed Brian Blessed there. I do apologise.
Massive beard, Julian. Incredible. Wow.
We better be careful here, Andy, because we're going to get into climbing stories if we're not careful.
Oh,
because he's climbed Mont Blanc about 50 times. And
no, only 1.5 times. Italian hospitals are lovely, you know. They're really nice.
Did you end up falling?
Yeah.
Hasten Hape.
What?
Go on.
High altitude pulmonary edema, high altitude cerebral edema.
Oh, right. Yeah.
Oh.
My climbing buddy knew there was a problem when he said, loosen the green robe. And I had absolutely no idea what green meant. I knew there were shades of grey, but I didn't know what the concept of green was.
Yeah, that's the safe word, isn't it? Again.
That's right, yes.
Yeah, and again, there are no safe words on this show.
Yeah.
If you talk to your colleagues, or if we start playing with the hypoxic training, if we
want to wear a GIMP mask, Mike.
Yeah. Okay. Yeah, if we ever actually get together and start doing that, I will only take you to about 3,000.
Be clear. You are talking about hypoxic training on a bike here. You are not talking about your kinky sex fetishes.
Green.
Is this our safe word? Green.
An AirPod case, or you just pleased to see me?
It was an AirPod case, yes. Well recognised. You know your Apple products. Other telecommunication products are available.
Are available, yeah.
Not good, are they? To be fair,
not as good.
No.
So hips and knees, Andy.
Hips. And Bumpsadaisy, of course.
Hips, knees, and Bumpsadaisy. So is that replacements or fixing?
See, now you're on to a big subject. Yeah, self-analysis. I'll give you a bit of self-analysis. I get bored. Okay, it's actually quite easy to get bored doing the same old thing.
I know.
I said many years ago, look, you could train a monkey to do our job. It's just that the monkey doesn't have a mortgage and a wife and kids to support. So the monkey would just fuck off and say, I'm out of here. I've done all of this. So,
oh yeah, you're right about that.
yeah.
However, monkey mortgages are available, and very often they have extended families.
Yes, they do. They don't have responsibilities because they don't give a fuck about them, do they, Mike? That's the problem.
No.
Not in my experience of monkeys, but there is a monkey story that I could tell you here that would link to that, and link it to
bonobos might.
bicycle things.
Bonobos might, but strictly speaking, they're apes rather than monkeys, aren't they?
Yeah, bonobos are.
But
But
speaking, of course, the phrase is "I don't give a monkeys."
well, yeah, that's very true. But I mean, obviously, most people would associate monkeys with chimpanzees, and well,
That's
I
a
spent
hybrid, isn't it, of some sort?
what, a chimpanzee?
No, a monkey crossed with a chimpanzee.
Well,
If
that
you
would be.
associate a monkey with a chimpanzee, you get some sort of hybrid.
No, they won't cross. They're
won't
too
cross.
genetically distinct. So
The chimpanzee is likely to, yeah, the chimpanzee is.
I'm trying.
No, the chimpanzee is likely to eat its mate.
I bet it's tried first. I bet there's a chimpanzee somewhere who's thought,
Foreplay.
that
What,
green
and then
monkey
eat
there's winking at me. I'm going for that one.
I'll eat you first.
Yeah, whatever. But
Bit of lipstick on.
in the work that I've done with chimpanzees, I was cautioned right from day one. You know, be careful with these guys. Well, no, what the analogy was be careful with these guys, because you give them a bicycle, and the first day they'll learn to ride it, and the second day they'll take it apart to find out how it works.
Really?
Yeah.
And time trialing was born.
And time trialing was born back in the 30s. No, I wasn't the birth of time trialing.
Oh, sorry. Yeah, well, it probably was the birth of prehistoric time trialing, wasn't it?
What, for me? So to help Julian and those that don't know, a time trial is the most bizarre form of bicycle racing, where each rider sets off to ride a certain distance down the road, and they sort of set off at 1 minute intervals. And seemingly in Britain, we're quite good at time trialing. All the big.
Where it all came from, Mike?
Well, it came from originally, as I understand it, it came from when racing bicycles on the road was outlawed.
Yep.
Is that?
It is. So bunch racing was outlawed. You're looking at really 1930s, 1940s.
Right.
So a few things happened. Number one, you couldn't ride a bike in a competition on a road. You could be arrested for it. So what time trialists did was they had a predetermined course. All the courses were ascribed a certain number. Now, I mean, it's a bit like the positive fish sign on the back of a God Squaddy's car. You know, the old religious symbol, etc. So the P841 is a course that starts in Funtington, goes down to the top of Chichester at the Northgate roundabout, and comes back and finishes just outside of Funtington. And time trialists would know that. The P gives you the idea that it's in the Portsmouth, Fareham area, and the 841 is another sort of suffix that tells people where it is. And so they were starting at a particular time, pushed off at a certain interval. They usually wore black, so that if they were stopped, they didn't look like they were in team race colours, etc. And so that's why the majority of cycling gear nowadays is black. That and the fact that actually, if you have shorts of a different colour, it does almost show what religion you are. So, you know, there's got to be something.
Yeah, it's not pretty, is it? There we go. The history of time trials.
Yeah. Orthopaedics. Okay, so hips and knees.
Yes. Yeah.
Back in the room. Hips and hip replacements, knee replacements, all sorts of different sorts of those. I must admit, I find the whole concept that here we are in the 21st century, you've got a slightly worn out hip or you've got a worn knee, have a chunk of metal and plastic. I find that a little bit defeatist. Oh, your hip's worn out, have a hip replacement. However, having said that, they are massive success stories. So the 20th century really was innovation in terms of joint replacement, how you do it, what you put in, how you improve the outcome, etc., etc., etc. And there's no doubt about it, they have been phenomenally successful. But they're very much end-stage treatments. You know, your joint's knackered, have a new one. And it's not without its complications. Regrettably, I see a lot of young people. I saw a young lad yesterday. He's 16. I did his hip replacement just before Christmas.
What?
Yeah, seriously. Sequelae of childhood hip condition called Perthes disease.
Oh, no, we see that in Westies, in dogs.
Yeah.
Calf leg Perthes disease. So it's femoral head ischemic necrosis.
Yeah, absolutely. And then the problem is how the femoral head remodels. And if it remodels concentric ball in socket, they'll do very well. If it remodels flat mushroom, they'll do okay, but they'll have restricted movement. And if it crumbles, then you've got a hip that's knackered and you're going to put a joint replacement in it, and otherwise wrong age to do it. To be fair, this young lad is delighted. And I did it just before Christmas, and just before he was discharged from hospital, he said, best Christmas present I've ever had.
Well,
he was able to go out for a walk with his mates, but then would spend 3 days in bed because he was really struggling. Now he's kicked the ball around, he's more or less pain-free, he's got quality of life back, you know, etc., etc. So that's great, and there's no doubt about it. It is a massive success story. But there is an economic problem with doing joint replacements in young patients, because you look at the fact that they have a bearing surface which is non-biological. It's only ever going to wear out. And when it starts wearing out, the problems are that it starts loosening around the implant, and then you're doing another one, which never quite lasts as well as the first, etc., etc., etc.
Yeah.
And that's if it all goes well. If you have complications, etc., then you run into the issues of funding the treatment for those complications. So it's interesting that we mentioned Perthes there, because of the 3 childhood conditions: Perthes, slipped upper femoral epiphysis, where the growing part of the ball just slips back,
popped off,
and dysplasia, so when the hip socket is a little bit shallow. What we know is that the shape that the hip develops influences whether or not that hip is going to last you a lifetime. And it's probably more influential than what you do with it in your lifetime. So fascinatingly, there is now, and you probably do get this in animals as well, Julian.
We get all of those in animals, yeah. I could see we could fill the whole evening up chatting about those 3 things.
Yeah, but hip impingement is massive, massive, massive business, and it's just so poorly recognised. So if you imagine a ball in a socket, if the ball is beautifully spherical and the socket, it reciprocates it, and they both point in the right direction, you've got a hip that will move really, really well, and it will do pretty much anything you want to do. But once you get the hip up to that sort of position, with the neck of the femur touching the margins of the acetabulum, then you've got impingement. And what happens is the hip actually starts levering out. And you can see that on radiographic imaging when you screen patients that have got this problem. Fascinatingly, the growth of the hip finalizes itself round about, in blokes between sort of 16 and 20, or that can be a bit earlier, and in girls sort of 14 and 18. And the load that you put your hip joint through in those years influences how your hip develops. So if you play a lot of impact sports, American football, ice hockey, basketball, football, rugby, it changes the shape of your hip joint and makes you much more susceptible to developing hip impingement. We can see that on X-ray. Okay, so just park that one for a moment. If you look at patients that are about to have a hip replacement, somewhere between 70 and 90% of them have hip impingement as an underlying diagnosis. So the whole concept of idiopathic arthritis or arthritis with no known cause, it just doesn't exist. It's bollocks. We know why patients get arthritic hips. So 2 questions arise from that, really. One is, can you do anything about it? I.e., you know, can you change that? And secondly, how do you identify those patients earlier than they've got arthritic change? And actually, it's not too difficult to do. The difficulty is in the surgery to correct it. And actually, that's what I've moved more and more and more towards. And we're doing a lot of that with keyhole surgery now. So it's safe, it's well tolerated, it's pretty darn good. You know, 90% of patients are happy. And you're changing the shape of the hip joint. So you're decompressing it to make people more comfortable, give them quality of life. But also, you're probably impacting the joint replacement rate for hips in the future. Now, that may not sound like much, but we do on average 90,000 hip replacements a year in the UK. So that's potentially 70,000 patients a year could avoid having a hip replacement. That's huge.
That's massive, isn't it? And so, are you then concentrating with the arthroscopic approach on changing the angle of certain regions of the acetabulum?
No. So yeah, it's defining what's normal there. And I think this is the concept that a lot of people don't quite get with regards to hip impingement. It's not just change the acetabulum, which is what you probably need to do if you've got a dysplastic or underdeveloped hip. And that's a much bigger operation. And I must admit, I saw a few of those when I was training, not interested in doing them. It's big, big, big surgery. But what you're looking at is changing the growth-related effects. So the reason that patients get symptoms in hip impingement is because the labrum or the seal around the hip joint gets damaged. It's got a rich nerve supply, it's got a very rich blood supply. So when it's irritated, it bleeds and it hurts. It bloody hurts, basically. So you need to preserve the labrum, but you've got to treat the impingement. And all of our learning from this really came from, well, what's causing the damage to the labrum? I mean, I can show you a whole load of fluoroscopic images, so intraoperative pictures, when you take a patient's hip through a range of movement, an ordinary range of movement, something like sitting down on the loo, for example, where their hip is getting to a point where they've got a bump of bone and it's going. So the poor old labrum sat between a rock and a hard place, quite literally. So you've got to give that room. So what I'm concentrating on in particular is what I call a functional range of movement. So if you're a ballerina, unless you've got a dysplastic hip, you will impinge because of the range of movement that you're putting your hip through. So with those people, you shouldn't offer them surgery. That's behavioural modification. You say to them, look, just stop doing it. Doctor, it hurts my head when I do this. But don't bloody do it then.
Yeah.
Whereas if you've got someone who is a former rugby player and who can't even sit in a car without getting discomfort in their hip, and then they can't get out of their car before it goes clunk and they go, oh, fuck, hip's gone again. Those people almost certainly have impingement. You can change the way that hip joint articulates with keyhole surgery.
Well, we have all those problems with dogs, the calf-Perthes disease. As I said, pretty much, not mainly in Westies. We've seen a few other breeds, but mainly
Is
Westies.
this because Westies do ballet, Julian?
It's because Westies do ballet, absolutely.
And
You
they
should
get
see them in a
tutus
tutu.
and
It suits them so well.
Yeah.
But they've got 4 legs. Is it not called a 4-4?
So what we tend to do is we usually don't manage to save the femoral head. So we're then faced with either doing an excision arthroplasty, and most of them do very, very well with that, or putting a THR, total hip replacement in.
Yeah.
With hip dysplasia, then we often see a youngish group, so juvenile Labrador, for the sake of arguments, 8 to 10 months, with signs of intermittent hind limb lameness and a bunny hopping gait up the stairs and things that gives us an indication there might be hip dysplasia. The X-rays will show us that there is. And if they're young enough, so if they're before about 11, 12 months, then we'll either try and do something called a pubic syntheodesis, where we essentially cauterize the ventral part of the pubis, which allows then the dorsal part of the pubis to continue growing, and it flattens the pubis out a little bit. Or we do a TPO, a triple pelvic osteotomy, and swing the acetabulum out of the position. Now, to give you an idea of how successful that is, the TPO was initially called a totally pointless operation.
Yeah.
Although with improved implants and improved measurement of the angles with three-dimensional CT, etc., it's become a lot more successful. Although syntheodesis is still a bit of a, might work, might not.
Is that a genetic thing, Julian, or is that
a variety of effects and of causes rather? There certainly is a genetic aspect to it, because we know that certain breeds are more prone to it.
Right.
Not just due to anatomical similarities or differences, but some very anatomically similar breeds will have very, very different ranges of hip scores.
I'm just thinking about the whole Alsatian thing and the, back in the 50s and 60s.
Sloping back, etc.
Yeah, and they're now like this, aren't they? They can barely open their hips up at all. Yeah,
and that's been muted as a cause of both hip dysplasia and lumbosacral stenosis and things like that. And so breeding and genetics have their factors to play, their part to play. Nutrition, particularly in the early years, is a great modifier, usually a negative modifier. Sorry?
Vitamin D, is that important in dogs?
It is, and actually it's usually the other side of that that vitamin balance, which is over supplementation with calcium. So a lot of clients, particularly with those bigger breeds, will want to feed calcium supplements to their dog, and that creates a vitamin D, calcium, phosphorus imbalance, and tends to lead to really asymmetric growth in a lot of the joints.
That's fascinating. I'm going to get topical.
Yes, go on then.
Yeah, I love this argument, but the actual scientific basis behind skin color and race and ethnicity, if you want to call it that, is entirely down to sunlight and vitamin D.
Yeah.
There is no genetic difference between anyone. And if Julian's probably slightly better able to cope with it, but if Mike or myself lived in sub-Saharan Africa 200 years ago, we would have been wiped out by skin cancer. So our genetic heritage would have gone straight away. Similarly, if our darker skinned relatives had lived in Scandinavia, they would have suffered with vitamin D deficiency, osteomalacia, rickets, etc.
Rickets, yeah.
And so they wouldn't, let's put it bluntly, they wouldn't have been able to run around. They would have been bandy-legged and pretty useless, and nobody would have wanted to mate with them. So their genetic line would have died out. So actually, it's natural selection, and it's purely down to sunlight and vitamin D. And so I'm very keen on that as a concept. And anyone who has any issues with race, ethnic equality, etc., just needs to realise that they might use colour of skin as a means of differentiating people, but actually what they are is they're culturalist. They don't like that culture, whether or not that's religion, creed, or whatever. And it's just sickening. It's born out of ignorance. I'll get off my soapbox.
Yeah, I quite agree, Andy. And I'll be honest, there's one culture of people, I think I can say, one culture of people I don't like. I'll be perfectly honest, I don't like lip readers. And I'll tell you there's a reason for that. The reason is that I think they're quite sneaky, lip readers, and they know exactly what you're saying from way across the room. They're kind of spies in a way. And I apologise to Dame Edna for nicking her joke on that.
They call plays on American football, don't they? And the coaches have got their headsets on and their microphones, and then they hold their thing up and they sort of go, and they're calling.
Mike, can I congratulate
you? Queen.
Can I congratulate you for getting the educational content and advertising the journal there, and not having or whatever it is that was actually on top of it.
So for those that weren't able to see, Mike is now holding up a journal that says it says Veterinary Anesthesia and Analgesia. It's an Elsevier publication.
I read that as analgesia. I thought that was something completely different.
Andy, seriously, the quality of some of those papers, you're absolutely right.
Yeah, but it's nice and shiny. You can't really wipe with that, can you?
You can't.
Guys, can I just bring up something important, which is that my drink is empty.
Oh, okay. Off you go then.
I've got another gin here, and I think you might be quite interested in it because there's a bit of a story behind it. Okay, so this is
from the Queen, is it?
No, this is gin. This is another Chilgrove gin. So the last one I had was Chilgrove.
I thought you said You said it wasn't royal. Isn't Chilgrove Estate something to do with Charlie or whatever his name is?
No. Highgrove.
No.
Oh, that's Highgrove. Okay. Pardon my ignorance.
Chilgrove is not far from us, Chichester, mate.
Yes, local. So it's really nice gin. I like it. They're not our sponsors yet, no. But other gins are available. But this is also a
depending on
Chilgrove
how much
gin.
they want to pay.
And what I've done is I've got a certain flower in here. I'll tell you about later. But if you put a little bit of lemon in this, watch what happens. Nothing. Hold on, I'll stir it.
The lemon floats, Julian.
The lemon floats, and this worked very well in all the rehearsals earlier. I'm going to squeeze a little bit more.
For people who can't see this, this is live science, and Julian is holding up a glass here of a deep purple blue drink.
It's clearly not changing colour.
A lemon slice.
Oh, there we go. Do you see it's turning slightly purple?
Glass.
It was purple anyway.
Still purple.
No, it was blue. It was blue before.
Purple from purple. So
yeah, it's definitely purple.
Do you know the reason?
We're not very good at science, Andy. we're not really the science guys on this one. Yeah. I think you might need.
The reason this isn't working very well, I'll let you see. So what it's blue. It's supposed to turn purple, and it will do with an increase in acidity.
Yeah.
Decrease in pH.
You probably need some tonic in there, mate.
See, no, I made it earlier.
Yeah.
And of course, tonic is acidic, so I put a little bit of bicarb soda in just to buffer it. And I put a bit too much in, so it's not working very well. However, it does taste very nice.
So what are the put bicarb in? His lactate tolerance has gone through the roof there, Mike. We should get him doing an interval session now.
Yeah, absolutely.
The flowers. Hold on, I've got to tell you the flowers. The flowers are amazing. They're I got them when I was in Thailand, and they're called butterfly pea flowers. But the Latin name is great. It's Clitoria tenorata. I've got a picture here. This is the flower.
I don't know why it's called that. I'm married.
So it just shows that the botanists in the 1800s didn't get out an awful lot. But I was really pleased with myself because I knew we bought these back from Thailand, and I thought I'll ask my wife where they are. I thought no, I will find the Clitoria myself, and I managed to.
Yeah, so, right.
How many years of marriage did it take you to get there?
It took a long time. I almost gave up several times, I'll be honest.
Yeah.
But I found it in the end. First for men everywhere. Cheers.
Yeah.
I put far too much bicarb soda in this. I'm terribly sorry.
That will have an
after.
What
are the key botanicals of this particular gin then, Julian? I've seen this one around. I've declined to pick it up.
Pea flower, obviously.
Yeah.
So it's truly balanced, summer's day gin, sound of leather on willow. Hang on, what's all this about?
That's cricket.
That's cricket at Chilgrove.
I've no idea. It's gin, okay, Mike. Look, Mike, you've probably got a special clip again, haven't you, about a nice gin that you're preparing?
Well, we could probably show one or two tonight. Yeah.
Do you want to show that? I'll read about this gin, and
what? And I'll introduce you into one of my special gins.
What I'm going to make for you tonight is a spiced gin. It's called Opia. Well, I'm told that's how it's pronounced anyway. Instead of doing the regular citrus bite with it, what I'm going to do is I'm going to crush a couple of cardamom pods and pop those in, and a sprinkle of pink pepper into the glass, followed by thank you, the ice, and a generous measure of this curry in a glass. I'm looking here just to bring out some of those wonderful Asiatic flavours. Should we start again? Forgot what I was saying. Okay, ready? So, in with the swizzle stick, and here we go again. Switch those bubbles, down we go. Mixing in there. As I say, nice light tonic water, so we don't detract from all the spices and the herbs in the gin. There we go. Up here, gin and tonic. A curry in a glass. Cheers.
I have here a blue-coloured solution. Look, I'm going to add some lemon to it. And
it's magic.
Isn't that incredible?
It's still blue.
Fucking thing.
No,
it's not. Look, let's not. Look there. Look. Yeah.
It matches the colour of your shirt perfectly. It's almost like you planned it.
It's changed colour.
Oh, it's now turned
there
purple.
You go. It's now turned purple. Clitoria tenorata.
Fantastic, Julian. Well done.
Don't ever put bicarbonate soda in your gin and tonic, mate.
No.
There are quite a few
ice in your gin and tonic. Ice.
Trialists have tried using bicarbonate of soda in their warm-up drinks to act as a buffer for lactate.
Don't start me
I've avoided ever trying that because they do say that one of the side effects is potential gastrointestinal rush, shall we say. The last thing you want when you're about to race on a bike is a need for a toilet. It's distinctly unpleasant.
I can foolishly bring it back onto orthopaedics.
Yeah, go on then.
Because I'm out of my depth on cycles. I've got a cycle, a really nice bike. I get no time to use it, and when I do, it's normally going along the flat because my wife and girls don't do hills. Anyway, orthopaedics. Do you use any stem cells? I know they're a bit experimental in humans, but so stem cells. I've had a few successful cases now, or I've collected falciform fat, sent it off for stem cell enrichment, and then injected it into elbow and/or hip joints.
Yeah, so the jury's out on that, and there are several reasons for it. Number one, there's the inconsistency of what you're injecting. So there was a vogue for platelet-rich plasma, so aspirating or taking a sample of blood, spinning it down, concentrating the platelets, which have a lot of inflammatory mediators in there, and you inject that. The problem is, depending on the time of day, how much coffee you've had, what your actual phenotype is as a person, all those things vary what you got from PRP. The sort of uniform thing with PRP was that it hurt a hell of a lot more than a standard injection of local anaesthetic and steroid. So the patients got a hell of a lot of pain from it. Now, there are some really good uses and some people that have really been avid proponents of it. One of the guys is the Barcelona surgeon, Ramon Cugat, who, look, I'm a Man City fan, so I've read a little bit about him. And all of their professional footballers, when they're injured, they go and see him largely because of his work using PRP, biologics, etc. And there potentially is some merit there, because if you can inject something and get a professional footballer or any sports person back to competitive sport 48 hours earlier over a 6-week recovery period, they might play one game more. Because, of course, they're a commodity. Does it change the long term? Almost certainly not. But there are things like, going back to what we were talking about with hip arthroscopy and the labrum, etc. One of the problems is if you can't get the labrum to heal, and there are definitely biological changes that occur that are age-related. So over the age of 45 to 50, repairing the labrum is more or less futile. It just doesn't work. There are some exceptions, but generally speaking, it doesn't work. So if, for example, we actually had a biological scaffold that we could use, that we could put some stem cells into, that would actually make that biological scaffold something that was not only biologically living, but also perform the function of the labrum in the hip, actually that would be of significant benefit. But we're just not there with the technology at the moment. It's a bit hit and miss.
We don't know whether those stem cells are going to be directed to make the cells we want them to make. I again use PRP on occasion at the practice. We have our in-house hematology analyzer will tell us the concentration of platelets we've got within the sample that's yielded, and of course our patients are not necessarily coffee drinkers, so So there is an argument for more consistency being available for dogs and cats, but I agree it's semi-experimental stuff. I got it to trial, and then realised that I have absolutely no way of maintaining and performing a consistent clinical trial, nor would I have Home Office approval to do that. So I'm following the recommendations by the people who supply it and using it in that way.
But it's also how you measure outcome in your situation. I mean, we can get a questionnaire to patients, and they can tick a box to say whether or not they're better or worse, etc. But even then, you're reliant upon the material that you're dealing with, because quite a few patients, and I've had this before. So, Mr. So-and-so, how is your knee doing? Oh, it's great, it's fantastic. So why on the questionnaire have you written you're in extreme pain? Oh, my back's been murder. Yeah, but it says here knee questionnaire. What is it about that you don't understand?
Yeah. We have similar things. We have questionnaires that we can send out to the owners, and they'll work out roughly what answers to give to make you happy that you've done a good job. And we have more objective measures like force plate analysis.
Yeah,
we can do. We have gait assessment, and particularly with good old iPhones. Other phones are available. We can do slow motion studies.
Not Huawei anymore though.
So yeah, experimental stuff. It is all experimental stuff.
Yeah.
Cruciates. How are you doing cruciates these days?
Hamstring reconstruction.
Mm-hmm.
I still use that because it's reliable, and the insult to the patient is pretty low. That's a reliable operation.
Is that the pull through?
Yeah, we fix them with an endo button at the top, and I use just an interference screw at the bottom. The thing with cruciate ligament reconstruction is that you can never have enough fast cars to satisfy knee surgeons. So they have to find a new technique of doing it, and they have to advertise how good they are, etc., etc., etc. And the bottom line is, it is a collagen interposition graft. Put it in the right place, fix it reasonably well, rehab the patient, boom, done. Don't argue the toss. Double bundle, triple bundle, quadruple bundle, interference screw, suspension fit, blah 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 blah. Just do the bloody operation correctly. And if you do it right the first time, they'll do well.
And make sure they have physiotherapy afterwards.
Yeah, exactly.
Yeah.
Also, choose your patient.
Didn't that originate in equine surgery, Julian?
I don't know. Don't do horses. They kick me.
All right.
But we have. I do routinely. I do 3 types of cruciate surgery. A lateral suture, so we're placing a polypropylene implant or explant.
Tenodesis.
Yeah. I do a TPLO, a tibial plateau leveling osteotomy.
Yeah. And
a TTA, a tibial tuberosity advancement.
Yeah.
How do I decide? Well, pretty much. Owner expectation is the answer.
Something that I feel really, really deeply about. So if you find me on Facebook, you'll see what I wrote. And it was really my experience of my first on-call with coronavirus, because operating in PPE was fucking horrendous.
Yeah.
It was grim. You know, when you're dealing with trauma, you know, where you wear a lead apron, you're x-raying through the case. The case is going on for 2.5 hours, etc. And you can't breathe, and you're completely covered, so you're just sweating from every origin. There's nowhere for it to go.
As if there wasn't enough stress anyway of trying to work out where bits should go anatomically.
Yeah, although to be fair, surgery is surgery. It's not difficult.
No. You have to concentrate on it though.
Yeah.
More or less.
A lot of it becomes second nature, but you're right. You do have to concentrate. It's muscle memory, which makes a massive difference as to how good people are as surgeons, because they'll remember where their hands were at any given point in the operation. And there's no more operation that's more important for that than hip arthroscopy, because you're in a deep spherical joint, going through quite a big soft tissue plane, and you're drilling into someone's pelvis. So it's not only where the tip of the drill is, it's the angle that you're drilling at. And looking at a flat screen in front of you, and you've got a complex 3D structure. You know, you've got all that shit going on. But that muscle memory is really quite stark, and it's amazing that we are able to do that repetitively, even though each patient's anatomy is different. So actually, there is a real skill to that learning, but it's all subconscious.
It is. I about 3 years ago, I started doing laparoscopy.
Yep.
And I do several laparoscopic spays a week now, and other laparoscopic procedures. And the first couple of dozen I did, I was thinking, how on earth do people manage this? And now, I'm teaching other people, and I'm showing them. I'll just say, I'm going to pop the spleen over to one side and have a look what's going on here, and pop it back. And they say, how do you do that? And you think, well, we have no idea actually, but you just do it.
I've got a registrar that I'm teaching at the moment because he wants to come and work alongside me as a consultant, and he should be absolutely fine with it. But when he's stuck, I'll just say, well, hang on a moment, let me just, and I'll do it. And he looks at me as if to say, you bastard.
Yeah.
Well, the answer is I've done 2,500.
Sure.
So, it's just repetitive learning, isn't it? And like
it is. But it is a depth of field, and it's a distanced proprioception, isn't it?
Yeah.
So you're being aware of things at a certain or even uncertain distance. Because I did a lap spay on Monday on a 4 kilogram dog, and on yesterday on a 50 kilo dog, and the distances there and the size of everything is very, very different, but it's exactly the same muscle memory. And when you've got used to working at a distance, then it doesn't seem to matter exactly what that distance is. And you must have the bariatrics. You must have some really quite large people with huge tissue planes to get through to find it.
Thankfully, those people I can just turn and say, look, I can't make you better unless you sort yourself out first. Go away, lose weight. I can't get into your hip joint. Yeah. There are extra long instruments to allow you to do that, but you can't do anything when you get in there, because when you think about it, you're operating down a tunnel, and if that tunnel is that long, in order to produce that much movement at the tip, the
tunnel's got to be that wide,
and it's resisted by the entire tissue plane depth. Yes. So you just can't do it. That's simple vectors. And just angular geometry there. So forget it. What's really funny is when you get a grasp of what you're doing yourself. So when you watch someone else doing an operation, you'll see that they want to look around the corner. And of course, we use a 70-degree scope for arthroscopy in the hip, as opposed to a 30-degree in the knee and the shoulder, etc. And so you can look around by rotating the light source, rotating the camera. When you want to look around a corner, you watch the number of people that do this. It's really funny. And you want to look a little bit further back. So.
Yes.
And I do it myself. I'm well aware of it. But it's bloody funny nonetheless.
Yeah, I know. My assistant who I'm teaching to do lap spays at the moment is very much like that. I'll say, well, look, just the ovary is going to be just caudal to the kidney. And she'll go,
yeah.
Look, move
around the corner there. It is very funny. I think we've got a good generation of surgeons up and coming, simply because of video gaming, PlayStation, etc., all that sort of distance stuff. There's a lot of robotic surgery used now.
Yeah, I think so. I do like getting down and dirty though, and rummaging through joints with bare, well, not bare hands, but gloved hands.
Place, isn't there? There's a definitely.
That's interesting you say that, because I was one of the guys the other day, and he went to ring the doorbell and used his thumb, and that's because they do thumbs on text. And
that's interesting. Phone. Yeah, that's just wrong, isn't it?
And he went to ring the doorbell with his thumb.
How bizarre.
And I sort of wonder what age that cutoff is, where we lost the use of this one and started to use this one more often.
That is interesting. I must admit,
From writing this way.
from writing.
Are we at that point then, Julian, where we need the CPD certificate? Have we had an evening of CPD on?
Yeah, CPD, completely pointless dialogue.
CPD, continual professional development.
Continuing.
Is it?
Or continuous. Completely pointless dialogue, seriously.
We're going to report you to the RCVS.
We are.
Yeah.
It could be completely pointless dialogue. However, it's not, because we are reflecting on the information we've learned.
Oh.
Should we do that? A little time to reflect?
No, we need the certificate first.
Oh, yes. There we go. I've got a certificate. There we go. So yet another CPD certificate. If you have received this certificate, then you have benefited generally in life from watching veterinary ramblings. It's got today's date.
Ramblings. Veterinary ramblings.
Ramblings. What did I say? Rambles?
Yeah.
It's the bicarb.
Yeah, I think it is. Too much bicarb.
And there are a few orthopaedic injuries. We'll tell you about this chihuahua in just a moment, but in order to get this CPD certificate, we've got to reflect.
We do have to reflect, because that's part of the whole CPD thing, and that it requires reflection on the CPD that you've received or delivered, because you get points for delivering CPD. Wow, we must have hundreds of points, Stuart.
Thousands of points, thousands, yeah.
Oh,
yeah.
So if this is a panel show, who won? Who adjudicates?
Mike and I adjudicate. You didn't win, Andy, sorry.
Julian, tonight. Mike, how many did you get?
What, points?
Yeah. I'm a competitive cyclist. Did I win?
You came within the top three.
Yeah.
No, podium.
Yeah, podium.
Yeah.
Podium.
Fantastic.
Game on.
So let's just briefly for a moment just pause and reflect on that. You're not taking reflection seriously, Julian?
No, I am.
Okay.
Try and get the taste of bicarbonate out of my mouth.
You can't pour yourself a proper gin.
I'll go pour myself a proper gin. I've reflected. I'm going to pour myself a proper gin.
Thank you for joining us in reflection there, Andy. That's much appreciated.
That's fine. If I'd had a mirror, it would have been slightly better, but you know.
Well, you got the computer. That'll do.
Oh yeah, I did. Yeah, but the lighting is bad. I look as if I've been drinking all evening here. I mean, heaven forbid.
So this chihuahua,
chihuahua
with a fractured radius and ulna, I saw about 4 years ago, and it had broken its leg in a bizarre postman incident. So this little dog, the house, it was a maisonette, and so the front door opened immediately onto the stairs, which went up to the first floor. And this little dog would stand at the top of the stairs, ready to bark so loudly and so forcefully it would jump up off the ground whenever someone came to the front door. And the postman put a letter through the door, and this dog was incandescent with rage and bombed down the stairs, tripped, and hit the front door Superman style.
Yeah.
Fractured his front leg. And so I fixed it. Just a simple plate on the radius. Did very well. 4 months later, I saw it again. The owner said, lame again. I thought, well, okay, lame again is a pretty mild term for the fact that it fractured its leg pretty badly. So, okay, God, you know, what's happened? Is the implant broken? The screws pulled out? What's happened? But it was the other leg. Exactly the same fracture on the other leg. And I said to the owner, you know, what happened? I thought you said you were going to go baby gate there. She said, I did, but unfortunately I left it open. The postman came to the door, and I put my foot out to stop the dog from running downstairs, and inadvertently kicked him through the front door.
Oh
This
dear.
poor dog. You try hearing that and not stifling a giggle. It was fine. The poor dog was absolutely fine in the end. It did have some glass cuts, and the postman apparently changed his round.
Quite right too. Quite
Little
right.
4-kilo child bursting through the glass of the front door.
I mean, I have a couple. One of which is tragic. The other one is just classic Brummie humour, dare I say. They actually both come from when I was a junior doctor in Birmingham. One very, very poor guy had been involved in a road traffic accident and had lost a leg. And he'd also had
Very careless, and he looks everywhere for it.
Yeah, he did.
Yeah.
But the car had gone over it. Well, actually, that was an even worse one. A guy who was involved in a van accident just outside of Oxford when I was training there. And van rolled over, and he had a traumatic amputation of his arm.
Oh, gosh.
And the paramedics arrived within about 8 minutes, and literally one of the paramedics had seen the arm on the other side of the road, was literally just going across to pick it up. Car came around the other way and ran over the road. So reimplantation was not possible. Without giving too much away, guess what the patient's surname was? Hook. I shit you not.
Fantastic.
And then the last one, this cracked me up no end. Birmingham hospitals were never, ever quiet. But one day I was a houseman on call for surgery. And then they bleeped and said, "Oh, there's a patient for you." Okay, great. Wandered down. Casualty's empty. Where's my patient? Oh, he's round the back. Why is he round the back? Got loads of empty cubicles here. Yeah, you'll see. And this poor bloke was diabetic, and he had some very bad ulcers on his feet. And I wandered around there, and I kid you not, the stench was just grim. You see all sorts of things when you're a medic, surgeon. The stench from this one was just unbelievable. So there I am, sort of effectively holding my nose, trying to take a history from this guy whose leg is pretty rancid. Obviously very poor blood supply, ulcers, infection, the works. So how long have you had this problem? Oh, about 6 months. 6 months. So it's been smelling that bad for 6 months. Yeah, about that. So how have you managed to hide that from your wife? Oh, we sleep in separate bedrooms. Yeah, but what about during the day? Oh, well, I suffer with really bad flatulence, and I've been blaming it on that. So he basically rather claimed that he was pretty much shitting himself rather than his leg. Poor bloke.
Andy, when were you a junior doctor in Birmingham?
Now let me see. 87. I went to medical school there. I was.
That's all right. That's fine. That's okay. That's all right. That's okay. That's okay.
Was it you, Mike?
No. No, but I did used to habituate the A&E departments of Birmingham at the time.
Wasn't you? Was it Mike with the episode with the shall we say the rapidly vibrating humming instrument stuck in a body cavity?
No.
No. Okay. Because that is a wonderful apocryphal tale. I genuinely have no idea how true this is. When the rather quick-witted junior doctor says to said person who's got something shoved in a body cavity that's just stuck there, said, "I'm really sorry, sir, we're a bit confused. Are you here for a removal, or do you just want a battery change?"
Brilliant.
That's amazing. It's been absolutely fantastic. So we've done our introduction.
Mm-hmm.
We've done our CPD. We've had our CPD certificate. Is it time for a joke, Julian?
Oh, I've got a joke. I usually tell a really naff joke about now, and it's more or less incumbent on you as our guests to laugh heartily at it and say, "What a great joke!" You don't have to. So I was trying to think of something relevant.
You do actually, because he gets really hurt if you don't.
Is that what Monty Python would call a contractual obligation?
Yeah.
Yes. Yeah. It was in the small print earlier.
Ah, okay.
So I was trying to think of a joke that was sort of relevant to both of our orthopedic careers, and actually there's one thing that ties it together. I couldn't think of a One Health joke, but evidence-based medicine, evidence-based surgery. Because what does that mean? Are you practicing evidence-based surgery? Do you do that?
Okay, of course.
Yeah, and we always do. But actually, it struck me that what is evidence-based, and this joke I think really tells you what evidence-based is, and it's the teacher at school that says to the kids, look, I want one of you to come up with a sentence using the word definitely. And Mary puts her hand up and says, yes, miss, I know, because it's Friday. We're definitely going to have fish tonight, miss. Oh, yeah, okay. You might well do. Good little Catholics. You have your fish on a Friday night, but what if your parent goes out to buy, no, so I didn't say your mum goes out. Your parent goes out to buy the fish, but it's off, or the fishmonger's closed, or she can't get in due to coronavirus, or whatever. So, you might not. Anyone else? Miss, yes. Well, my dad will definitely pick me up from school tonight. Well, yes, Daniel, but what if he has a fatal accident on the way home? What if his car's stolen or something? So it's highly likely, but not definite. And this goes on for a while, and eventually Johnny puts his hand up. Yeah, miss, I've got one. Yes, Johnny, what is it? Well, yeah, I've got a sentence, but I've got a question first. Yes, Johnny. Yeah, do farts have lumps? No, Johnny. Oh, I'll definitely shit my pants then, miss.
Oh, dearie me. Do you know, Mike, we didn't get on to talking about litigation in the NHS. We've hardly touched on cycling. We really have rambled, haven't we?
It is a ramble. There's nothing to it. There's no structure to it.
No.
There's ever a structure, we've failed.
Oh, yeah.
Did you want to talk about that then?
No, we'll have to come back.
Please do.
You'd be very well.
Very happy to have you back.
Andy. So on that note, can I say, Andy Langdown, thank you very much indeed.
Gracias, amigo.
Thank you for coming.
Thank you for joining us.
One absolute pleasure.
May your dog go with you.
May your dog go with you.
When lockdown has finally gone, we'll do this in real life without the cameras, because it was a blast, guys.
Sounds good. It was really good fun. You can see the fingers there, Andy. So this is a little slight there, little nod to Dave Allen. May your dog go with you.
Yes.
Yeah, well, we don't want to get too really.
God bless.
Yeah,
but yeah, definitely. We'll meet up when lockdown's over.
Yeah,
it'd be good to do that.
I'd enjoy that.
Just remember, green.
There's no say.
And cut. Oh, mate.
So do you see how professional it all is? You're actually quite amazed, aren't you?
That's it. That's the show. That's the wrap. That's it. Have you enjoyed yourself?
Fun now it was great fun. Great fun. I love our chats, Mike. Look, we shared a few trips up to Alkmaar, a few up to the velodrome. I love talking bollocks with you.
Thank you.
It's just awesome. And Julian is the absolute perfect foil. It's brilliant. What great fun.
Well, it's we enjoy it. It's a Wednesday night of pleasure. Good fun.
Yeah.
This is our sort of finding sanity in the middle of.
Oh man, right.
That's excellent.
I need to go and reacquaint myself with the family. Guys, we should do this again, but we should, Mike, sort it out and we'll meet up, because that'd be awesome.
Yeah,
that'd be great.
I'm really thrilled. Andy, you've been amazing tonight. Thank you very much indeed.
Bless you.
Yeah, thank you so much.
Cheers, guys. Take care.
You take
care, Andy.
Bye.
Bye. Take care.
Off. Go.
Oh, that was fantastic, mate.
Enjoy
really good. Yeah, fantastic. What a great guy.
Yeah, he is. He's a super guy.
Yeah.
Super guy. And as he said, we didn't talk about cycling and any of that sort of stuff.
Tantalisingly small amounts of everything, wasn't there? There's just too much to fit in. Hello, everybody. Thank you all so much for supporting Veterinary Rambling so far. We really appreciate every single one of you for tuning in to enjoy our show.
We have loved interviewing people over our first season, but we really need your help to continue.
No, we don't want to make a profit. We only want to help support our post-production team, who've given us 100% from the get-go.
Mm-hmm.
It takes, would you believe, on average, 8 hours of editing work to take an episode from film to release. And we want to help support the team who make this possible for us.
That doesn't surprise me. I'm surprised it's just as quick as 8 hours, to be honest with you. and seriously, it's a testament to the guys, because we've worked with a number of fabulously creative people who very kindly donated or commissioned artworks for us to offer as rewards for donations. I'll have another drink.
Have another drink. And while you're having a drink, people, please take a look, because we'd love to be able to offer you some sort of physical memento to say thank you for supporting us.
Yeah, the support would mean a world to us. We love sharing stories, and it's not that often that we get to see other human sides or other sides of the story when we discuss some of the medical or veterinary issues that we've chatted about. And
that's really what keeps us going, isn't it, Mike? Well, that's what we love about it. So we'd love to be able to continue what we do and expand our horizons further, so we can keep providing entertainment, education, and good conversations to the rest of our profession and to the whole world.
Oh, I like the whole world. So,
or at least the Isle of Wight.
Well, the Isle of Wight, yeah, especially the Isle of Wight. Although I think we've got somebody that listens on the Isle of Man.
The Isle of Man?
Yeah.
Wow, this is the big time, Mike.
Oh, yeah.
So what do people do to get more information?
Well, the best place is keep an eye on our Facebook page, or what we'd really like you to do is go to www.kickstarter.com. Search for Veterinary Ramblings Podcast Fundraiser. That's
what's that again, Mike? That's
Veterinary Ramblings Podcast Fundraiser, and have a look and see what we've got there.
Great. I'm going to look now.
Go do it.
How exciting.
Yeah.
May your dog go with you.
Oh, may your dog go with you too, Julian. Cheers.
Sure he will. Cheers.